All right, continuing on. I'm so sorry, guys. I kind of suck at life here. If anyone can help me find a recording software that can do more than 5 minutes at a time, that would be much appreciated. But in the meantime, I'm just going to be doing these little geeky 5 minute clips to put together these Kodachrome sessions because I'm too lazy to look elsewhere. So I was saying we have this stipple reticulated pink rash in the axilla. It's interesting. So when you see these axillary rashes, you can approach it in a little bit different way because you have to think about what's unique to the axilla. There's a lot of heat, there's a lot of friction, there's moisture, but there's also a lot of eccrine glands. So you're often going to need a lot more history. Is this bilateral? Is the patient on any therapies? Things like that to figure out what's going on. But I want you to think about this from a regional standpoint too, in terms of what's unique in this actual area. And so if we gave you a little bit of history that this is a woman who has been on chemotherapy, that might help you a little bit down the line. So this person has been on cytotoxic chemotherapy for breast cancer and has developed this painful red rash in her axilla, and this is known as malignant intertrigo, also known as intertriginous flexural xanthum of chemotherapy. And what's happening here is that places that have high quantities of eccrine glands are just going to statistically secrete a lot of chemotherapy, and when the chemotherapy goes to the eccrine glands, it damages them, and you develop an inflammatory response and a rash. And so it's called malignant intertrigo when it pops up in the axillae. And again, that's unique to this area because of how many eccrine glands there are. And the reason I really like this Kodachrome is I thought the appearance of it was very interesting, and I ended up looking up a lot more reports of it. And it often has kind of this arcuate array where it's not quite in the axillary vault. And I think there's some discussion about a high density of eccrine glands on the periphery like this. So it's really interesting that it almost outlines for you perfectly in this rash where the high density of eccrine glands are in the axilla. So I thought that was a pretty cool case. This next one is a young boy, and what you see here is this annular, scaly, crusted rash on his nose and on his eye brow. So you want to think about immediately annular scale is a fungal infection, so dermatophyte infection, and that's what this is. This is tinea faciei, but it matches your clinical impression, right? Because if you look at where the action is, this is an epidermal process. You could see that there's scale. This might even be a pustule. There's scale, so you know it's epidermal, papillosquamous. So that's puts you in that differential of things like psoriasis, lichen planus, tinea corporis, etc. But when you have it, especially on a young boy who's been snuggling a kitten or something like that, and they have this annular broad pink plaque with this leading scale, really not much is going to look like this, but tinea faciei. And the key being with tinea faciei is you're often going to need oral antifungals given the depth of the infection and because often these infections are zoophilic. So the kid is cuddling a guinea pig or a cat or whatever, and they get these organisms that will need treated with oral antifungals rather than topicals. This is a case that we saw in hospital consult. It's a good case. What are you seeing here? So we're looking at the right lateral neck and right ear. You're seeing well demarcated erythema with these pink to purple, almost hemorrhagic vesicles in a dermatomal array. So this is herpes zoster shingles. Not much else can look like that. We see this all day, every day on consults, and just good thing to know how to diagnose, to look out for it. This we also saw in consults. Really weird case. Interesting though. I did want to show you this because I do love that in dermatology. Dermatology, it's a little bit of a misnomer, the study of skin and experts in skin, but we also manage hair, nails, and oral mucosa, and I do want everyone to be aware that we're experts of those and should be experts in diagnosing these. So this was a patient who came in, a longtime smoker, complaining of this ulcer on his tongue. It had been there for 2 to 3 months and thought it was just because he bit his tongue, but it hadn't responded. So the main thing you immediately want to worry about, a long-standing ulcer, smoker or not, but especially a smoker, non-healing on the tongue, is a squamous cell carcinoma. And that's actually what this was. We took a small punch at the edge, and this was an invasive, well-differentiated squamous cell carcinoma. The differential you could think about of an ulcer on the tongue like this, there's eosinophilic ulcer of the tongue, which has been described. It's a post-traumatic ulcer thought to be due to chewing or some type of trauma there where you get an eosinophilic infiltrate. You can think about erosive diseases like lichen planus, but there's no inflammatory border here. You can get a sense that whatever is eroding this is because there's a bunch of cells in the actual stroma causing it to break down. So you just looking at this is non-inflammatory dermal neoplastic squamous cell carcinoma. And I'm going to stop there to switch over to another 5-minute recording.